Good evening, everyone. My name is Rich Riley. I'm a member of University Hospital's Marketing and Communications team, and I will be your moderator for our event this evening. I'd also like to recognize my colleague, Kelly, who's played an integral part in planning this event tonight as well. On behalf of the entire University Hospital's family, thank you for joining us for our webinar, Ready to Address That Nagging Foot or Ankle Pain. Tonight, we'll learn about foot and ankle pain in adults, its causes, along with non-surgical and surgical treatment options. So a few housekeeping notes before we begin. In this Zoom platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed during the presentation, please submit your question through the Q&A feature, and our presenter will address these questions at the end of her presentation. Also, this evening's webinar is being recorded and will be available for viewing on demand in the very near future. It will be posted to the University Hospital's website, and as an attendee of today's session, you'll receive an email with a link to that presentation. I will also add that oftentimes we will experience, or every once in a while, we'll experience some technical difficulties. So if perhaps we lose the feed or we lose our speaker, just please have patience. We'll get everything back in order in a very quickly manner. But I'm sure we'll have no issues whatsoever tonight. So it is now my pleasure to introduce our presenter, Dr. Shawna Miskovsky. Dr. Miskovsky serves as the head of the Division of Foot and Ankle Surgery for the Department of Orthopedics at UH Cleveland Medical Center, and is also a well-respected and accomplished sports medicine specialist for University Hospital's Sports Medicine Institute. She received her Doctor of Medicine from the University of Pittsburgh. She completed her residency in orthopedic surgery at the Ohio State University Hospital and completed her fellowship in sports medicine at the Houston Sports Medicine Foundation, as well as a fellowship in orthopedic foot and ankle surgery from the American Sports Medicine Institute. Dr. Miskovsky is extremely busy. She is the head team physician for Case Western Reserve University Spartan Athletics. She also serves as the head team physician for the Lake Erie Storm Athletic Program. Working with the United States Olympic Committee's Sports Medicine Division, Dr. Miskovsky has served as the team doctor for the past 3 Paralympic Games. Dr. Miskovsky noted, "It is truly an honor to meet Team USA Paralympians and provide them with medical care. The Paralympic athletes embody the true spirit of the Olympic movement. They not only are amazing athletes, but amazing people. That's why I serve them." I will also note that Dr. Miskovsky served as the team doctor for Team USA figure skaters competing in the 2018 World Figure Skating Championships. It is my pleasure to introduce to you Dr. Shawna Miskovsky.
Good evening, everyone. It's my pleasure to be here tonight to go through some foot and ankle problems and answer your questions and see if we can make you feel better. So I'll go through some basic terminology just because there's a lot of vocabulary and terms that might be thrown at you. And so as you try to learn about your foot and ankle condition, I think knowing some of the terms is helpful. And so if it's review for some of you, that's certainly fine. Going through the ankle first, you have your tibia, which is your shin bone. You have the inside part of your ankle that's a bump called the medial malleolus. Malleolus in Latin means bump, so it's just a funny term. The fibula is the bone on the outside of the ankle, called the lateral malleolus also. And then you have your talus. So the ankle joint is actually made up of your tibia, your talus on the bottom there, and also your fibula. The joint below the ankle that helps you go side to side with your foot is called the subtalar joint because it's below the talus bone. And it's formed by the talus and the calcaneus, which is just a fancy term for your heel bone. When you go past the ankle, so the ankle joint from the side, you see the tibia, talus, subtalar joint below the talus and your heel bone. So the ankle joints here, we call the hind foot, kind of this area here between the heel bone, the talus, and the navicular. The midfoot is in this region here between the center part of your foot. And then the forefoot, we turn from the metatarsal bones, which are these long bones here, distally or toward the toes. So here is the forefoot. So just some general terms to help help you navigate when you're trying to learn about your condition. So I'm going to go by where it hurts. And so the outside part of your ankle, we call the lateral aspect in terminology for medical people. So the outside of the ankle can hurt from many causes. And so some other terms that are important to know is that a ligament connects one bone to another bone in general. Tendon is actually a muscle plus a tendon unit, kind of like a spring system. And so the muscle attaches to bone on one end, and the tendon attaches to the bone on the other end. And so when the muscle contracts, it pulls on the tendon and then moves your foot or your ankle. And so if you have a tendon that tracks well in a groove in a bone, it's like a pulley. When the tendon doesn't track well in the pulley, or if the rope essentially comes out of the pulley, that's called a dislocation or a subluxation. So just some general terms to help you understand. So the outside part of the ankle, there's only so many things that can cause the pain. I'm not going to go through every single condition on every slide, but I'll hit the high points for you. So ankle sprains are really common injuries, and there's two types of ankle sprain. The most common is called the low ankle sprain. And so as you can see on the picture on the right, the ligaments are torn because the foot is twisted in. We call that inversion. And it's usually from a sport injury, trying to do some lateral movement. You step on a rock when you're jogging, the foot gets inverted, or you twist your ankle. And so a ligament tear is a sprain. So there's different types of tears of the ligament. So we regrade them. So grade 1 is like a tweak. So only a few fibers of the rope essentially are torn. So think of each ligament as a rope. Grade 2 is when half of the rope is torn. And grade 3 is when it's completely ruptured or torn. So in this picture here on the right, the anterior talofibular ligament is completely ruptured. And it joins between the fibula and the talus. So that's why it's called the talofibular ligament. There's also another important ligament called the calcaneal fibular ligament, which helps stabilize your ankle when your foot is in more kind of straight, flat on the floor position. So football, soccer, basketball, very, very common injury. The ankle gives out. A lot of times you'll get pain on the bone structures of the ankle that we talked about. And so in that case, if you have pain, it's hard to walk and the bone's sore, we usually have to get an x-ray to start to make sure there's not a chip fracture or a bone injury. A lot of times, fortunately, those low lateral ligaments, they heal very well without surgery because they have a very good blood supply. So for the majority of people that have this injury, we're able to treat you without surgery, but we have to let the ligament heal, or if there's two ligaments involved, let them heal. And so we do that by providing some structural support to the ankle so that you can walk better, you're not limping and not aggravating the ankle further. So if you have a very bad sprain or a grade 3 sprain, we may have to put you into a boot. If you have a milder sprain, we might be able to use an ankle brace. The key though is we have to get your rehabilitation done, because if you don't get your muscles activated properly after an injury, you'll tend to re-sprain your ankle or retwist it. And we have to recheck and retrain those muscles to fire at the proper time and retrain your balance. So resistance exercises get strength better for you. Proprioception just means that you know where your body is in space. That helps you figure out where your balance is and helps you not fall again. So that's the main. You want to make sure you don't re-injure your ankle. So recovery time really varies depending on the severity of the sprain. You can have a type 1 or grade 1 sprain that's only a few days and you're feeling reasonably good. Grade 2 sprains can take sometimes 4 to 6 weeks. Grade 3s can take 6 to 8 weeks where you're feeling a little bit under the weather with respect to your ankle function. And so getting care and making sure you do your rehab is really important to get back to your sport or activities that you like to do. On a rare occasion, we have to get an MRI to actually see if there's another injury that occurred with the sprain. So you can have a tendon injury, you can have a cartilage defect. And I'll go through some of those ankle sprain mimickers that I call them in a later slide. So those are things that present like an ankle sprain, but actually aren't an ankle sprain. Surgery is indicated only if you're having problems with the ankle giving way multiple times. You're not having good balance, you can't push off, can't do lateral movement very easily. And so at that point, we usually have to do a scope of the ankle, which is a little fiber optic lens that we look in the ankle joint, because usually there's scar tissue and cartilage damage from the recurrent sprains. And then we do an open incision generally to repair the ligaments and get them tight again. Make sure those ropes are the right length like they should be. The high ankle sprain is a bad actor. So these are the sprains that keep our football players out for 8 weeks, 12 weeks, even longer sometimes. And in the picture on the upper right-hand corner, you can see that the foot and ankle is hyperdorsiflexed, we call that position, and everted. So it's the opposite of inversion. It's toward the outside or eversion. And so what happens is it twists and actually tears the ligaments that make up the high ankle sprain area. And they're not as common. They're about 10% of the time. Again, soccer, football, probably the most common. Slalom skiers get this injury too. Another way to think of it is everyone's seen slalom skiers before. So think that you get your ski stuck on the pole and your ankle gets turned and rotated to the outside or externally rotated. And you can imagine having your ankle, your foot up and your leg externally rotated or turned to the side outward and rotated. That would cause an issue over the high ankle sprain area. So this is what it looks like. So think of the high ankle sprain ligaments as a zipper that holds your tibia to your fibula bone. And so there's an interosseous membrane that goes all the way down. There's also two different ligaments to help connect the tibia to the fibula that are important. So that's a front view, that's a back view of the ligament complex. So it's quite strong. So when you have these injuries, they are higher energy injuries, meaning that it took a lot of force to tear. And generally the tenderness will be in a different spot than what we saw for the low ankle sprain. It'll be kind of in the front and a little bit higher up. So that's why it's called a high ankle sprain instead of the usual low ankle sprain that hurts more down in here in this area below the fibula. So the management, again, depends on the grade. If you have just a tweak, so to speak, we can usually get it better without surgery. If you have a rupture where it's a grade 3 tear, which is what's shown in this picture here, you can see there's no overlap between the tibia, this is the edge of the tibia here, and the fibula. So this bone should be over here. There's a little bit of a groove you can see in your bone, or a little concavity, and that should actually fit in there better. So the ligaments were torn in the syndesmosis. And this is MRI vision or picture of the same thing, of that ligament tearing. So what we have to do in some situations is do an ankle scope and actually stabilize the ankle ligament complex. And we do this by using a little device that has suture in between, and we call it and a little button on one side. So basically you get the bones where they should be, so the ligaments scar down and heal in the right length. Because again, you want the rope to be the right length, not stretched out. If the rope's stretched out, that means your joint has too much motion or flexibility and it can come in and out of place. And that's when you get the recurrent injuries and sprains. And so we drill a little tiny hole, pass a little button that flips on the bone that kind of stabilizes on one side, and then another button stabilizes on the other side, and it pulls the two bones together, basically regenerating that nice zipper that I was talking about, that nice alignment between the two bones, the fibula and the tibia. So these are always a longer time to return to play. Rehab is very important for these to recover well. So you have to be a little more patient with a high ankle sprain. Typically, we'll have to use a boot for the most part for high ankle sprains because of the severity of the injury. So there are some mimickers. So you can get chip fractures or avulsion fractures. All that means is that the ligament can attach to the bone, and when the ligament gets a lot of force, it can actually pull off a piece of bone. Or you can have what's called a capsule, which is a fibrous tissue, kind of like a balloon that surrounds two bones together to make up a joint. And so if that capsule gets, if your joint gets a lot of stress and it bends, it will actually pull off a bit of bone from that injury too. So these avulsion or chip fractures generally don't have to have any surgery on, but they do suggest that you had a more significant injury. And so they can present in a similar way as a sprain, meaning that you twisted your ankle stepping down the stairs. You can also have a chip fracture instead of an ankle sprain. The other things that can sometimes mimic or happen with an ankle sprain, you can get a cartilage defect. So this is an MRI on the right bottom corner with the shin bone or the tibia and the talus. And you can see that there's a white line underneath here. And this is a pothole essentially of cartilage and bone. So we call that an osteochondral defect, osteo for bone, chondral for cartilage. I basically call it a cartilage pothole because that's a lot easier to remember. And so these injuries can occur also and cause ankle pain similar to a sprain. Or you can have a sprain with a chondral or a cartilage injury. There are some more rare conditions that can cause neoplasms. Tarsal coalition is very common in kids and sometimes can present like an ankle sprain, but they don't really have a good actually injury that they can remember. They just have pain in a similar area that you would have with an ankle sprain, but they didn't fall, they didn't twist the ankle. So a tarsal coalition means together. So the tarsal bones of your foot, between your talus and your calcaneus, or your calcaneus and your navicular is more common. They'll actually have a fusion, or they'll have a bone bridge between the bones, so they don't move as well as they normally would. because they have either a soft tissue, like a fibrous, thick thatch type tissue, or actually extra bone that joins them together. It never really separated when they were developing. And so tarsal coalitions can also present like an ankle sprain. So those are some of the mimickers that we think about. The peroneal tendons, so we're going to talk a little bit about tendons now. The peroneal tendons run on the outside of the ankle also. And so you can see on the picture, there's a short one that goes to your metatarsal, and then there's a long one that goes across your foot. And so the one that's the short one is actually most important for giving you strength to pull your foot to the outside, or eversion. And so that tendon particularly can get injured with a sprain. And interestingly enough, they run in a tunnel, these two tendons, and it's called the retinaculum. And so occasionally you can actually dislocate these tendons and they come out of the groove, similar to a rope coming out of a pulley. You can also get tendonitis. So tendonitis is basically inflammation of the tendon, or if you looked under a really high-powered microscope, you would see little tiny fraying of the rope, but it's not ruptured or torn in two. So it's an inflammation type overuse injury. So meaning that your tendon gets a lot of damage and your body can't heal the damage in time before the tendon gets stressed again. And so it can become a cycle where you get inflammation of the tendon, you get that micro damage that you only could see if you had a microscope. You get that micro damage, your body tries to heal with normal tendon, but sometimes has scar tissue put in instead, or calcium deposits get put in instead. And so when that happens and you don't have normal tendon anymore, that's called tendinopathy, or basically meaning bad tendon in Latin. So the tendonitis can happen over and over, can lead to tendinopathy or the scar tissue in the tendon or the calcium deposit in the tendon. So we really want to try to catch the tendonitis and get it healed first, so it doesn't progress to where it gets a degenerative tendon or the tendinopathy condition with the scar and the calcium deposits. So a lot of times the peroneal tendons help you with uneven ground. If you're trying to climb a roof or an incline, they're very important. They can sublux, they can tear, and they can track poorly in the groove of your fibula. So a lot of times, fortunately, if you don't have a dislocation or a problem with it not tracking in the groove, you can usually treat peroneal tendonitis without surgery. RICE just is an acronym for rest, ice, compression, elevation, which is pretty good for pretty much almost every musculoskeletal injury to help make you feel better. Physical therapy, definitely important. For the most part, if people have a lot of pain, we may have to use a boot to give you enough support so the tendon can get some rest and heal. Sometimes you can get away with just a wedge in the shoe or insert. We very rarely inject cortisone just because it can slow the healing process. And so we try to avoid that unless the pain is significant. And occasionally it can actually tear the tendon. And this is a picture in the bottom right of the tendon tearing in half. And so in those cases, because the tendon's torn in half and also out of the groove and not tracking right, we have to do surgery to fix that, usually with an open procedure. At times we can take a scope and actually go up and down the sheath or the tunnel where the two tendons run, and we can actually evaluate the tendons that way to see if the tear is there or not, and then proceed if we need to with the incision to actually get to the tear. So front of the ankle pain, there's some things that are important to know about. So impingement means pinching. So I'll go through what that looks like. It could be either soft tissue or a bony spur. Arthritis can occur and cause some pain in the front of the ankle. Synovitis means inflammation of the joint. And so if you do a lot of impact activity, sometimes the joint will get irritated, and the synovitis occurs where the joint lining gets really thick and inflamed. Crystalline just means like a gout type of condition where you form crystals in your joint, which are almost like fiberglass shards and are really irritating to the cartilage, and that can cause some problems with the joint getting irritated and getting synovitis and becoming painful. You can also get the OCD or the osteochondral defect we talked about. Sometimes it'll give you some pain in the front, usually front side or front, inside or front outside. There's also a big tendon in the front of the ankle called the anterior tibial tendon. And sometimes people can have a foot drop, or they can have a tendon tear causing a foot drop or weakness that will give you the same area of pain. So that's just some of the things that you worry about. The impingement problem is common in athletes, but also common at the first stage of arthritis. As your body tries to stabilize the joints and make a bigger surface area for where the forces are going across, your body makes these spurs, which makes the area bigger. The force is less, but unfortunately the spurs hurt because they block motion. So this is more of an athletic individual that doesn't have a lot of arthritis yet, but you can see where the arrows are. There's a large spur both on the tibia and the talus on the side view. And then on the bottom right corner, there's a picture of a scope view, actually, with me looking and seeing how big the spur is. So a lot of times we can remove those spurs through 2 tiny incisions and try to regain some of that motion and get rid of that pain in the front. Otherwise, in the most part, unless they're pretty big, this happens to be a pretty big spur issue here, but if the spurs are smaller or if it's just soft tissue, we can actually treat it without surgery with therapy. Some active rest, I call it. So maybe not running and jumping, but maybe doing biking, swimming, trying to get conditioning better before we progress back to running. Inside ankle pain can be also from a number of things. Posterior tibial tendon is a tendon that helps support your arch. So it kind of runs on the inside part of your ankle and attaches to that circular mark that I made. That's called the navicular bone, the tuberosity. There's also ligament called the deltoid. That's a very large ligament complex. That's 7, 8 parts of it to it that helps stabilize your ankle on the inside. You can get arthritis of the joint below the ankle, will give you pain along here. So there's quite a few things that can happen. The navicular is an interesting bone. It's a comma-shaped bone. It goes all the way across the center of your top of your foot. And so occasionally you can actually get a stress fracture in that bone, which is a difficult bone to heal because it does not have a good blood supply. So people will tend to have pain right in the spot here, right next to the tibialis anterior tendon, just to the outside of that. That's called the end spot. So this is just an anatomy picture. So there are a lot of stuff on the inside part of the ankle, obviously. The posterior tibial tendon is the one we'll talk about. You have your neurovascular bundle, which means the nerves, arteries, veins. We call it a neurovascular bundle. And you have your Achilles tendon in the back. So posterior tibial tendon dysfunction. So that means the tendon doesn't work, essentially. So the tendon has had tendonitis over time. It's led to scar tissue in the tendon. The tendon's not good at holding up the arch anymore, and it essentially stretches out and your arch falls. And so if you look from behind someone that has an adult flat foot, you'll see that their foot's rotated to the side or out. We call that valgus because we shouldn't see that many toes. If you look from behind from someone, you should only see about a toe and a half, and that's normal pes planus. So a big myth in some ways is that we should have a high arched foot. Actually, we should not have a high arched foot. The problem with a high arch is you can't shock absorb, and so that causes a lot of problems with people. We want to have a normal pes planus, so just a slightly flat foot, because that allows us to shock absorb when our heel hits the floor, but also allows us to look to stabilize the arch and actually make a rigid lever arm to push off with. If you have a high arch, you just have a rigid lever arm the whole time, and that makes it just doesn't take the stress very well or the impact very well. So you should have a slightly flat foot. Obviously, the picture is too far gone with respect to that's a collapsed arch. And so this would be characterized as adult onset flat foot deformity or dysfunction of the posterior tibial tendon. And so there's various ways we can treat it. It's mostly treated without surgery. The stage 1 just means that it's tendonitis mainly. And so we have to offload the tendon, usually with a boot, sometimes an orthotic, activity modification, and then progression back with some therapy. Grade 2 is when actually the arch is collapsed, but it's flexible. So that's when we use the orthotic. So the pictures in the upper right here are of a full-length orthotic that has a good arch support. And we can use that in an athletic shoe, a lace-up shoe. But what it basically does is it helps hold your foot in a better position when you're doing your activities. And so that takes stress off your posterior tibial tendon or the arch tendon. And so it's a very, very nice way to treat it. If stage 3 is more when you get arthritis, so if you have a foot that's kind of not in the right position, it's similar to having your car tires crooked on the axle. It's going to wear out your axle. So if your foot's crooked on your because of your arch collapse, it's going to cause some arthritis because of the increased stress on the surrounding joints. And so when you get arthritis, at times we can still use the orthotic, or we can use a brace that goes above the ankle to give us a little bit more control and offloading. Just take some pressure off the foot and ankle more when you go above the ankle with a brace. We can accommodate it with the orthotic, but sometimes if the arthritis gets bad enough, we actually have to do surgery to fuse the arthritic joints in the right position so the foot is in the proper straight position. Sometimes if you have more of a flexible flat foot, we can do what's called a tendon transfer. So we follow, that's the bottom right corner. So we find the bad tendon that's kind of shredded and has tears in it. The rope's not, it's sprayed basically. And we find the tendon that runs near it, and we recruit the tendon transfer, or the new tendon, we recruit it to become the arch tendon. So luckily there's some crossover in how our body works, in that we can take one tendon to help another tendon. And basically, we reroute that tendon transfer to become the arch tendon for us. So going to the back of the ankle. So a lot of Achilles problems cause pain in the back of the ankle and the heel. You can also get impingement or the pinching problem. And so we'll go through some of this with you. So Achilles tendonitis is very common and it can progress to tendinopathy. So on the picture on the upper right, you can see that there's like lumps in the tendon. So those lumps are from scar tissue and also calcium deposits. It's very common in runners because it's a high stress type of activity for your Achilles. So when you're walking, it's about 6 to 8 times your body weight on your foot and ankle. When you run, it's almost 13 times your body weight on your foot and ankle. So you can imagine that stress done repetitively without having good balance in the exercise routine can lead to some damage to the tendon. Or sometimes health conditions like diabetes or thyroid problems can make the tendon not healthy to begin with. And then you add some of the stress of just being active and trying to be healthy. Sometimes that can combine to cause problems with the tendon. Hyperpronation refers to when you have a little bit too flat of a foot and your subtalar joint is everted too much. Cavus foot, because it doesn't shock absorb, can put a lot of stress on the Achilles tendon. The Achilles tendon also is not blessed with good blood flow, particularly in this area where you see a calcium deposit on this x-ray. That's where the blood flow is not good. And so it tends to either rupture there or you tend to get the calcium deposits or scar tissue from the tendinopathy there. You can also get insertional tendinopathy at the back of the heel that forms almost like a pump bump that some people call it, and it can rub in shoes and cause some issues. The good news is, for the most part, we can treat the tendonitis or tendinopathy without surgery, usually with the boots and good physical therapy, and working on the flexibility of your calf muscle. So think of your Achilles as a spring system that has 2 muscles that form the tendon. So you want to keep the muscle as flexible as possible so it doesn't keep tweaking the tendon or hurting the tendon. So unfortunately, sometimes you can actually rupture the Achilles tendon. That's usually a very forceful acceleration or deceleration maneuver, like you're jumping up to grab that rebound, or you're trying to slow down and cut and then do a lateral shift on the soccer field and you feel like a pop in the back of your ankle, like someone kicked you. And typically patients will look around and there'll be no one around that could have kicked them. And so it's a very common scenario. It takes quite a bit of force to rupture. That just means that the 2 tendon ends are not together anymore. So the pictures in the upper right show a normal Achilles from looking from the back. So you can see a nice contour all the way on the left-hand picture. On the right-hand picture, you can see that it's swollen and that Achilles tendon does not have that nice rope-like appearance. So there's a rupture in the middle of it. And so just looking and comparing side to side is very, very good to see if that's what the case is. So most people, if they're athletic or high performance athletes, we're going to tend to try to fix them because they have better push-off power. If in other cases, patients might do better without surgery, functional results are almost the same, surgery versus not surgery, and the lower demand or lower activity type of athlete or patient. And so it's a very long discussion about expectations, what people like to do, where they are in life, their health conditions. So it's quite a long discussion to try to determine what would be the best option for everybody. The old surgical technique, we used to have to make a longer open incision. Nowadays, we can do it through a small incision, which is the lower right-hand corner picture. So the clamp, this little metal thing on the top here is a clamp, is part of the Achilles tendon that's ruptured. And so we can make a small incision here and 2 small, tiny incisions at the heel and actually repair the Achilles tendon now, which is helpful because it'll make the healing process quicker and we have less problems with wound healing. Sometimes we're not able to do it with the small incision technique, but if we can, it's certainly a nice technique to try to avoid the complications that are more well known from surgery, like wound healing problems. Heel pain is very, very common. We all pretty much experience it. It's basically the back pain of the foot and ankle. There's many things that can cause heel pain. We talked about the Achilles tendinopathy or tendonitis problem causing the back of the heel to hurt. Plantar fasciitis and other things can occur. So plantar fasciitis is probably the most common. So the main myth about plantar fasciitis, it's not a heel spur on the bottom of your heel. It may feel like one, but actually there's not a spur. It's actually a rounded, very smooth shelf. And the reason we have that shelf on the bottom of our heel bone is because we need something for our toe muscles to attach to so we can move our arch muscles and our toes. And so that actually does not get taken off ever. probably about 75 to 100 years ago, they used to try to take off that shelf and people did terribly because it's not the problem. The fascia is a fibrous tissue. It's like thatch. It really helps support your foot. And so when the picture in the upper right shows when your foot is flat, you don't see that separation from the floor. But when you extend your big toe and your other toes, see how your arch forms? So when you extend your toes like that, that's when the plantar fascia gets tight and it pulls up your arch. So you can imagine if you're walking and you push off and your toes bend up, you're tightening your plantar fascia, giving your foot extra support so you can stably push off your foot and walk properly or jog properly. And so the fascia actually does not attach anywhere where that shelf is on the side x-ray that people always call a spur. Unfortunately, plantar fasciitis is a mouthful to say. And so sometimes we simplify it and just say heel spur, but it's really not a heel spur at all. So you don't have to get it taken off. It's a good thing. It's very treatable without surgery over 99% of the time. You don't need any surgery for this condition. It's a little bit of an overuse type of condition, or if you're having shoes that don't have good support, sometimes that'll cause some issues with the micro tearing of the fascia. Some athletes, like some famous quarterback, could push off hard and actually rupture the fascia. And so that takes a little bit longer to recover from, but you still tend to do very well without surgery. We do not try to reattach the fascia because it just doesn't work well long-term and the results aren't good. So plantar fasciitis typically will hurt in the bottom right-hand corner, kind of on the inside bottom of the heel. And it gets worse in the morning because as we sleep, we have our foot kind of plantar flexed down. And so the calf muscle gets tight, the fascia, the fibrous tissue gets tight. And so when we take that first step in the morning, your arch goes like that. And it causes it almost it doesn't rip per se, but it causes a feeling like it's going to. And that's why you have pain with first starting up in the morning. And as you get walking, that pain gets less and less. There's also some associated tightness that can contribute to the plantar fascia getting more stress or force when you walk or stand or do your activities. And so we really have to target the hamstrings and the calf muscles to get more flexible. That will offload the plantar fascia. So conservative treatment involves stretching. So these 3 stretches that are pictured here are super important to get rid of this condition. It helps preserve flexibility and improve flexibility. And it really has been shown, even if patients have this condition for 2 years, still most patients will get better with this protocol. But you have to remember to stretch. So that's a little tough, obviously. So you want to pair it with something you do every day anyway. So you want to try to stretch 3 times a day for just a few minutes, less than 5 minutes, for about 6 weeks till you get your flexibility. And then if you do it before you work out or exercise on the long term, you can maintain your flexibility that way. The lower right corner, we're stretching the calf muscle. So the trick here is that back foot is internally rotated or pigeon-toed position. And what that does is it locks your arch joint so you can get a better stretch on your calf muscle. So it's like the runner stretch, but with the modification of pigeon-toeing that back leg so you can stretch that left leg in this picture. The hamstrings, you can stretch however you would like. You can touch your toes, you can sit on the bed. You can use some TheraBands or little bands that you use in therapy to go up and down with your leg and stretch your hamstring in more of a dynamic way instead of a static. Static means you just kind of hold the stretch. Dynamic means you move through your leg through range of motion as you're stretching. Formal therapy also can be helpful with a physical therapist. Night bracing are the night splints that you hear about, and that keeps the foot up during sleep. And so it keeps your calf muscle constantly stretched out. And so when you wake up in the morning, you don't get that ripping sensation as much. Casting, pretty rare at this point. Sometimes a cam boot will be helpful because it offloads the fascia, particularly if the arch tendon is also irritated, which is common. Sometimes the arch tendon and the fascia can be irritated because they both try to hold up the arch. And so in those situations, sometimes a boot works a little bit better for a few weeks to calm everything down and get the flexibility and strength better. You can use cortisone on certain occasions if the pain is more significant, but there's some side effects. And so you really have to be judicious and talk with the patient and the athlete about goals and how they're doing. One risk is rupturing the fascia, which is a little bit painful. The other is losing some of that fat pad that we have on the bottom of our heel bone. That fat pad is almost like a honeycomb, so it's very good for shock absorption. So sometimes if you have too many injections, you can actually lose that cushioning, and we can't really replace that fat pad on the heel with any surgery or any injection, unfortunately. So always have to be just thoughtful in how you use injections. The midfoot or the top of the foot, a lot of times happens with a midfoot sprain, so you can get what's called a Lisfranc injury. These are the ones that are pretty high energy also. Usually it's the linebacker who's pushing backwards and there's a forceful push off and they'll pop in the midfoot or in the arch and have sudden pain and won't be able to walk. So that's more of a Lisfranc injury. You can get fractures in the area, arthritis of the arch, or the navicular stress fracture that we talked about, or avulsion fractures. So it can give you pain in the top of the foot. So some highlights, the Jones fracture is one that you have to be careful with. It's a fifth metatarsal, so on the upper right-hand corner. The fifth metatarsal is the one on the most furthest to the right. And you can see a little tiny line coming across the bone. So the Jones fractures are bad actors also because they don't have a good blood flow to this bone in that area. And so they don't like to heal. There's also there's a tendon and also what's called a lateral band in the plantar fascia that attach here, and the tertius tendon also attaches here. So between the two tendons attaching on either side of the fracture, it's very hard to keep it still, so actually knit together or heal. And so in these situations, particularly in people who are pretty athletic or people that have problems with healing in general, we would recommend, sometimes to actually do surgery to stabilize the bone, to actually decrease the rate of refracture and get people back to sport or activity a little bit sooner. Non-union means that the bone doesn't heal, so a fracture cannot heal sometimes. And so we try to minimize that as much as possible. So if we're going to try to do without surgery treatment of this type of fracture, we have to do strict no weight bearing, meaning that we cannot touch the foot to the floor for 6 weeks. Because again, that vibration repetitively of hitting the floor with your foot can cause that motion, micro motion at the fracture. Because of the poor blood supply, because of the tendons attaching there, it can lead to not healing or a non-union. Or a delayed union just means that it takes twice as long to heal as it should. Usually it's about 6 to 8 weeks for an adult bone to heal. Sometimes diabetes can make it up to 3 months. Smoking can sometimes make it up to 3 months to heal. So it depends on a lot of factors, what treatment we select. But in general, this is a fracture you have to be careful with. Stress fractures can also occur, and we get this a lot in our active population, also our athletes. Even patients that walk every day for miles on end. You want to make sure you have a good cross-training program where you have variation of the loads that you're stressing your foot with. So one day you walk long, the next day maybe walk short, or you do a higher impact exercise like walking one day, and you do a lower impact exercise like biking or swimming the next day. That gives your body some recovery time to kind of heal the damage that's created by the exercise. Because when you exercise, you create damage. That's how muscles get bigger. That's how bones get stronger. But if you don't give your body enough time to heal the damage, it can cause a stress fracture and other issues like tendonitis that we talked about. So stress fractures are more of a fatigue fracture. So let's say you take a paper clip and you bend it a few times. It's not going to break, but the 5th time you bend it, it breaks. So similar to a stress fracture, it's fatigue. It's load after load after load causes a little fatigue in the bone. So the spongy bone, or the marrow part of the bone, is made up of a lot of plates and rods, so to speak, almost like little shock absorbers. So it's really good for shock absorption. So sometimes on an x-ray, we're not going to see a stress fracture because the marrow might be collapsed or fractured, but the hard outer shell, the cortical bone, is where all the strength is. And so unless we see a fracture line that goes through the hard outer shell or cortical bone, we typically won't see any stress fracture on the initial x-ray. Obviously, if we get an x-ray 3 months from the injury, we might see more calcium deposited at the fracture sites. That tells us that the body reacted to the stress fracture and healed it by putting more calcium down to heal the bone. MRI scans are sometimes helpful because we can see the marrow on the MRI scan, which we can't see on the x-ray. Fortunately, metatarsal fractures in general, if it's not a Jones stress fracture, most other stress fractures in the metatarsals heal very well without surgery. We generally have to use a stiff-soled shoe or a boot type of brace to kind of give some rest and immobilization and help with pain to help people walk a little bit better initially until about that 4th week or so, when the metatarsal stress fractures usually are on their way to healing. Sometimes they can be delayed healing, as we talked about, due to medical conditions, or if you're low in vitamin D or calcium. Sometimes that makes you at risk for getting the stress fracture, and also can make you at risk for not healing the stress fracture. So good nutrition is always important. And getting some sunshine too is important, but in Cleveland, it's hit or miss on that. Forefoot pain, again, basically from just a little bit towards the toes and a little bit of the metatarsal bone, constitutes the forefoot. So the most common thing we'll probably see in the office is bunions. And so it's actually a deformity of the great toe where it's crooked essentially. And what happens is the muscles that usually keep the toe in a nice alignment get thrown off course because the ligament that holds the toe on the inside has over time gotten stretched out. And so the whole, it's almost like having a horse on the reins. You know, if you turn the reins one way, the horse is going to go that way. So once the tendons get off center and they're not pulling in the right direction, they pull the toe into the bunion. And half the problem for this is related to hereditary that runs in families. Half the problem is related to bad shoe wear. So the x-ray on the bottom right, you can see someone wearing a shoe on the right-hand side. See how it makes that bunion happen because of the narrow pointy toe box. So sorry, all those fashion shoes, they're so cute and pretty, they actually cause a lot of foot problems. And this is one big one that they cause. And you can see that over time, that toe is going to be stretched out. It's almost like foot binding in some ways. You're wearing that all day. It's going to cause some damage over the time and the years. The picture on the left, this x-ray, is without the shoe. So you can see how much a difference a fashion shoe can make on the bunion development. So really proper shoe wear is key. You can use spacers between the big toe and second toe. You can do some bunion exercises and other things to try to help treat it. And a lot of times, as long as it's not severe, we can treat it without surgery, luckily. Unfortunately, we can't reverse it once it happens, but we can usually at least get it under control. On a rare occasion, if it progresses or we just can't get your pain better and your function is pretty limited, then we're considering doing some surgery to try to fix it. But again, most of the time, we just have to do some simpler things. Arch support also helps because that helps you push off your big toe nice and straight off of it rather than having it turn to the side. And then finally, lesser toes are very common. So you can have a hammer toe, and you can see on the picture, they can hit the top of your shoe and cause some pain on the knuckle. You can use little toe sleeves that are made of silicone. You can also use what's called a Budin, B-U-D-I-N, Budin splint to help kind of straighten out the toe if it's flexible. A lot of times you just have to make sure also that the shoes have enough room from the side. So you should have a rounded toe box. And also if you look from the side, you should have an extra depth toe box, meaning that you have more room on the side view of the shoe. So something like New Balance or that type of sneaker is usually the most common that people recognize. I don't have any affiliation with New Balance, but it's just an easy shoe to throw out there so people get the idea. You can get a claw toe, which is a little bit more significant. You also get a mallet toe. If you stub your toe, you can actually tear the tendon that straightens the toe out, and that's called a mallet toe. So it depends on the exact condition, but again, generally we have some tricks to try before any surgical correction. So that's just a fun overview of some of the main things that we see, and I'll be glad to answer any questions that you have. And this is our Paralympic team at Pyeongchang, proudly waving the American flag for opening ceremonies.
Excellent. Well, thank you so much, Dr. Myskowski, for sharing all this information. And again, if anyone has any questions, we have 15 minutes left, so I will start with the questions that have been submitted. The first question comes from Erica. What does it mean when your toes pop with each step you take?
So toes popping might be that you have some inflammation of the joint itself and the ball of the foot. And so when you push off, when you extend your toes, as we saw in the picture of the fasciitis slide, you can actually, moving back and forth, you can get some inflammation of the joint. It can make kind of a weird pop where it feels like you're walking on something. Sometimes tendons can pop if there's some scar tissue around them, kind of like a trigger thumb or trigger finger. I'm sure you've all heard of. You can sometimes get it in the toes. It's not as common. But those are two main causes.
Great. Thank you. So orthotic shoes, they are not the prettiest things to wear, but obviously they're not made to be pretty. But with that in mind, do they make orthotic inserts for heels or wedge sandals?
Yeah, that's tough because the heels generally don't have a lot of room in them. They're pretty tight. They do make some gel insoles that you can put in there to try to help. It's a thin layer of gel, but at least gives you some cushioning. So it's really hard to fit any orthotics in a heel. Unfortunately, heels are designed not the best for the mechanics of our feet. It makes us look good, but it's not the greatest the heel, even an inch heel can raise the stress on your ball of your foot by almost 75 to 80%. So it can really cause some problems. So unfortunately, no, there's not a great orthotic for the heels. Wedge sandals tend to slide a lot on the foot, so you do have to be a little careful. So try to get ones that have at least some sort of arch in them so that the heel part doesn't slide off and on your foot as you walk, because that can torque on your foot and cause some issues. There are some sandals called Naot sandals. Again, I don't have any affiliation with the company. I think they're actually pronounced Naut, but it's spelled N-A-O-T. And so it's actually an Israeli company that makes sandals that you can put orthotics in, which is great because you can take out the insert the shoe comes in with and put your insert or orthotic in there instead. So they're a good resource for that. And fortunately, you know, the orthopedic shoes, they're getting prettier. Still some work to do, obviously, but a lot of people like Hoka's, ABO's, New Balance. So they're getting some more contemporary looks now, as opposed to the more kind of, I always get the comment, it's my grandmother's shoe, or the SAS shoes and things. So we have a little bit more to choose from now. So hopefully with time, we'll get better and better.
Great, thank you. Next question is from Judith. What are the symptoms of nerve damage in the foot?
So compression can cause nerve damage. So sometimes if you have, we didn't really talk about it much, but tarsal tunnel syndrome is when the fasciitis problem causes a little bit of inflammation and pressure on the nerve. Similar in concept to like a carpal tunnel where you have pressure on the nerve. And so you'll get some tingling generally or numbness, sometimes burning pain, electric shock type pain. You can also get scar tissue on the nerve from an injury. That's called a neuroma, where there's actually a scar ball. It's like a not normal, flat, cylindrical nerve. It actually has a bump on it, essentially. And so neuromas can happen from pinching in shoes, from hitting your foot on the side of a cabinet, from, you know, lacerations that get the nerve. So there's many ways the nerve can get damaged. The other way nerves can get damaged is if a metabolic problem is going on. So diabetes, for instance, causes too much sugar to be deposited on the nerve itself. And think of nerves as electric lines. And so a signal passes normally very freely and quickly through the electric lines. That's why everything works and our power's on. Diabetes, with all the sugar getting put onto the nerve, makes the conduction not be as efficient and slow. And so you can get what's called neuropathy, which means that bad nerve in Latin, but it means that your sensation isn't normal in your foot because of the nerve got damaged from the sugar issue. Other things like thyroidism and other conditions can cause more of a nerve to be damaged. Other things, direct pressure, like a herniated disc, can actually cause numbness in your foot because all of your spinal cord and your nerves start in the spinal cord and they branch out. So if you ruptured your herniated disc, you can actually press on the nerve that gives you feeling in your foot. And so you get numbness there in your foot, which is sometimes hard to, you know, as a concept, hard to grasp, but just think of your spinal cord as a superhighway and it gives a map to the rest of your extremities. And so many different mechanisms with respect to nerve issues. So it all depends on the medical condition, trauma, you know, whether it's compression or not. So.
Great.
And generally nerves usually hurt a lot when you're at rest. They don't really have a time where they're not hurting or causing burning pain. Usually joint pain or tendon pain or ligament pain is worse when you're on it. And then when you're off of it, it usually gets better. But nerve pain tends to be a little more sinister. It might happen at nighttime all night. It might happen even if you're off your foot.
Thank you. Next question is from Carolyn. I have bunions and hammer toes. They're not shoe related. I'm having nerve type pain, especially on the top of the foot. So 2 questions. Is that related? And when is surgery recommended?
Yeah, so it's a little bit difficult to diagnose it over a webinar, but in general, if there's sometimes when you have bunions and hammer toes, the foot is bigger. And so pressure from the shoe sometimes can occur, causing some of that tingling on top of the foot. So making sure that if you go to a family-owned, not a chain, but a family-owned shoe store, they can actually measure your foot to make sure that the shoe width is not too tight on there. And unfortunately, we do change sizes with age. So as we get older, we can change a size or 2 or 3. Our foot get wider, or feet get wider. Gravity wins, I suppose. With respect to when to have surgery, it's really kind of a decision between your surgeon and yourself, the patient. patients generally, you can live with a bunion, but sometimes it comes to the point where they tell me that, the pain is every day, it's limiting my function, I can't do what I enjoy. I've tried the shoe wear changes, but it's really kind of a discussion with the surgeon to see, examine your foot, see what's going on, and then talk with you with respect to your expectations and what you're feeling, what your function level is to determine if surgery is necessary or not. Because obviously there are risks for surgery. Recurrence is one of them. The other is stiffness of that great toe joint after a correction. Even a perfect surgery, you can have stiffness. So it's always trying to measure the risks and benefits of your decision. So it's really kind of a personal thing with your doctor. But that's just some general comments on that.
Great, thank you. This next question is for Josh. He is asking where you see patients at.
I go all over the place. So I go to Westside at Westlake. I go to Chagrin at the Ahuja Medical Center in Beechwood. I also go at Mentor and also Mayfield. And so I also go to main campus, but only for trauma calls. So I generally just around the outpatient locations. So I know Route 90 very well, essentially.
Okay. All right. Well, thank you. This next question is from Nadine. She said, I had a rather deep cut from a blender blade that fell and cut the medial side of my foot below the ankle bone, but a bit forward. She said the cut is healed well, but it's still swelling and she has soreness at the end of the day. She says an ACE wrap helps. She wanted to know, just, in addition to that, any suggestions? She said it's been 4 weeks since this happened and she's still having these issues.
Well, that's a scary accident. I'm glad that nothing else happened. So it's good that the laceration healed and didn't get infected. So that's good. I guess you kind of worry about the tendon that runs there, the arch tendon, to make sure that's okay. It might be good to see somebody just to make sure that tendon's working. Sometimes you can get partially cut from that sharp blade because the blade always goes deeper than you think. It's kind of like a cat bite. The tip of the tooth goes a lot deeper than what the cut shows. So it might be worth getting it checked out if it's still pretty sore. Generally, if it's only partially, even if the tendon's partially cut, for the most part, if at least 50% is okay, you can usually hopefully avoid surgery. But it's probably something to check out if it's been that long. Swelling, unfortunately, because of gravity again, swelling can last months to a year after a foot and ankle injury. Unfortunately, we're always fighting gravity. But swelling generally does improve over time, but it just takes longer than we all like. So wearing like a compression sock or that athlete socks that are cool now that come in different colors that go up to your knee level, those help get the swelling down a little sooner. You wear them when you're standing.
Great, thank you. The next question is, can toe tip Silipose sleeve be purchased or directly, or does it have to be purchased at the office?
No, you can directly purchase them. Some CVS or Rite Aid may have them. They usually have the foam kind. I like the silicone kind. And again, I don't have any affiliation with this company. I just know that they have a pretty decent website and have the products. It's called HAPAD, HAPAD. So it's www.hapad.com. And then if you scroll by the tabs and pick, I think it's called PediFix, PEDIFIX, toe products, and then hit that tab, it'll come to those silicone toe sleeves and things. So I know they definitely have them. So if you want to check them out there first, I'm sure Amazon and other vendors will have them too. They may be cheaper, but I just know that company has them.
Great. And the second part of the question, what are Royce shoes?
They're kind of a hard sole type shoe. It has a little bit more room in the toe box. We sometimes use them. They're not as common anymore.
Great, thank you. This is coming from Carol. She noted, I rolled my ankle 2 weeks ago and have some swelling at foot bend between my foot and leg on top that goes down to my ankle. I can walk on the foot using a cane to help with stability, but don't have any pain while putting pressure on the foot. When or should I go to a doctor if the swelling does not subside?
Well, that's great news that you're still able to walk with not a lot of pain. So that's a good sign. That's probably more, hopefully a less significant sprain or twisting injury. Generally, swelling, unfortunately, as I said before, it takes a long time to resolve in the foot and ankle. So people are usually generally feeling pretty good, but they'll still have some residual swelling. So it's one of the factors to see how you recover, but it's not a main one. So what we look for is, do you have good motion? Has the stiffness gotten better? Do you feel like you're stable on your feet, that the ankle's not going to roll on you? And have you gotten back to you're able to progress back to your usual activities? So if you're not able to do any of those three things, or if you get pain on the bone when you walk, then it's probably good to see a physician. But swelling alone, unfortunately, is kind of a poor predictor of how people are doing, because again, it just takes a long time to get rid of it. And a lot of times you always have some chronic swelling after a foot and ankle injury. So it's just one thing you can watch, but it's not the main. So if you find you still can't get your motion, you find that you're weak, or you tend to lose your balance or stumble or roll your ankle easily, then you probably should get seen.
Great, thank you. To our attendees, we only have 3 minutes left. So we're going to finish the questions that have been submitted. And unfortunately, we will not be able to take any questions after this. So this comes from Kathy. She notes, have you ever heard of fatty deposits in the ankles? Described yellow fat similar to what you see in chicken. What do you recommend for this? And can this be confused with calcium deposits in tendons? She said the fatty deposits make her ankles look like she has edema.
Yeah, so we have fatty deposits actually everywhere. And they serve a purpose in most places. So we do have a tiny one just below your fibula that's like a little pad or cushion between the talus and the heel bone or the subtalar joint. So that's kind of normal. Sometimes if you have an injury, it can swell and so then becomes more prominent. So that's a more common one we'll see. Sometimes you can get what's called a lipoma, which is a group of fat cells decide to have a party and make a mass, and that can make kind of like almost like a nodule in the tissue below the skin. And so if you feel like it's a pretty big area, it's almost like a mass, and it might be good to get checked out. Sometimes we have to do x-rays and then MRI to see what it is. So fatty deposits aren't necessarily abnormal, but if they occur in strange places, then sometimes we have to look for the lipoma, which is the most common. Bad things are less common, but we want to make sure there's not a tumor that's going to act badly there. Again, that's pretty rare, but if it's bothersome or it impinges on how you can wear shoes, or you think it's getting bigger or smaller, changing in size, then sometimes it's a good idea to get it checked out.
Great. Next question, does spinal stenosis cause foot and ankle pain?
It can, because the pressure in the nerves in the lumbar area, particularly the lower lumbar part, can cause, it's called referred pain. So if you get pinched up in the back, you can actually get referred pain in the foot. Because again, all those nerves are like a map. We call it dermatome, because each nerve gives you sensation in a specific spot on your foot. And so if a nerve is pressed, it'll give you tingling or burning or pain in that area. So a lot of times you can get foot pain when you have a back issue going on. Stenosis is kind of like arthritis. It's almost pinches the spinal cord and the nerve roots that branch off of the spinal cord like a tree and go down to the legs. So stenosis can cause it. Herniated disc can also cause it. So it really, again, depends on all the symptoms you're having, but yes, you're correct in that comment.
Thank you. This next question is from Deborah. I believe it's regarding sinus tarsi. She said, this is the second or third time I've had it in my right ankle. How and why does it happen for a 60-plus-year-old inactive person?
So yeah, the sinus tarsi is kind of a fancy term for a groove that's kind of running along the subtalar joint that we talked about. And so when you have, a lot of times we'll see it where actually the arch is collapsed, and so you pronate, and so the heel tilts to the side as your inside of your ankle tilts inward. And so you can imagine it'll kind of jam your fibula bone on your heel bone. And the sinus tarsi is in between those two structures. It's made up of a little fat pad, it's made up of muscle, it's made up of the peroneal tendons. And so you can actually get a pinching problem because of the flat foot issue. And that's typically what we see in the sinus tarsi syndrome from. So it's not actually the ankle joint, it's actually the subtalar joint, the joint below tilting, causing a pinching problem in the sinus tarsi or that groove. Essentially the space is less there. And so a lot of times, for most patients, we try to use an orthotic to try to open up that space so the fibula doesn't pinch the structures and the heel bone as much.
Thank you. This next question is from Shirley. How do you differentiate heel pain, plantar fasciitis or a bone spur or Achilles tendonitis?
So really, it's most of it's from history, and another component of that is exam and actually knowing anatomy and knowing where the structures are located. Because plantar fasciitis is not going to be diagnosed if you're tender over the Achilles. So history plays a role. So plantar fasciitis typically worse in the morning when you take the first few steps, or if you're sitting for a while and you get up, the first few steps are pretty hard to do because it hurts on the bottom of your heel. So that's more of a plantar fascia problem. And as you get moving, because the tissue warms up, the pain gets better. Achilles tendonitis is usually more at the end of the day. So you've had a hard day at work, or you worked out hard, ran, you have pain in the back of the heel or the back of the lower leg that radiates. And so it's just a different location of pain, usually worse at the end of the day because you've used it all day and it gets inflamed. So that's one way we kind of strategize where the pain could be coming from. Stress fractures hurt in a different spot on the heel bone itself. And so it all depends on your history, like how it happened, was it a trauma, was it not trauma, how it changes during the day, what makes pain better, what makes pain worse, and then the exam part itself, just to figure out what structure is actually tender when we touch it or stress it.
Thank you. This question is from Jordina. Do you recommend yoga toes for foot pain?
Yoga toes I think they help people that have a little tightness or a little spasm or muscle achiness. So they definitely don't hurt. And so if you feel like it makes a difference, I think that's perfectly fine. They're not going to correct any deformity per se, but it might provide some cushioning and help, strengthen your foot. So I'm okay with those.
Thank you. This question is from Michael. He says, I walk regularly and have a bunion on my right foot. When I reach approximately the 3-mile point of my walk, I sometimes begin to experience extreme pain in the second, third, and fourth toes. Sometimes they become numb. What are my options for relief?
Yeah, so the big toe is the bossy toe. So think of the big toe as a main area where the weight is transmitted across. So most of your body weight, you need your big toe to be in a good position. And so when you have a bunion and the big toe is a little bit off center and a little crooked, so to speak, you tend not to walk straight off your big toe and push off correctly. You tend to walk a little bit toward the side of your foot. And what happens is it loads the ball of the foot joints and causes that pain in the ball of the foot. And there's tiny nerves that go in between the metatarsal heads, which make up like the ball part of your ball of the foot. Those tiny nerves can actually get irritated because you're putting more stress on them, because you're rolling to the side over time to avoid stressing the bunion. And so that's called stress transfer. And it's called metatarsalgia because it's the MTP joint. And so, it's pretty common in that type of scenario if you have a bunion. Obviously, it depends on your exact history and health conditions and things like that and exam. But in general, sometimes we have to cross train a little bit. So one day you walk long, the next day you walk short, or you do biking the next day, just to give yourself some recovery time so the ball of the foot joints don't get inflamed as much. You can try a metatarsal pad, which is a little pad that you place not on the ball of the foot, but there's a little sunken in spot just in the arch area, just before you get to the ball of the foot. And that's where the edge of the metatarsal pad should go. And so when you walk, you put more pressure there than on the ball of the foot areas that you're loading. And that actually might help out the bunion. Having a good arch support in your shoe will also help the bunion, so you can use your big toe more. So those are some strategies for you. Obviously, your personal situation could differ, but some general guidelines.
Great. This is from Diane. Diane notes, I had surgery for a heel spur and Achilles tendon transfer last fall. She came through the surgery just fine. About 5 months ago, she developed posterior tibial tendonitis that has caused her great pain. She said that she has done band stretching, Graston, dry needling, and recumbent elliptical. To top it all off, she found out she needs a knee replacement on the same leg. Her question is, do you have any suggestions for overall greater pain relief?
Yeah, sure. So occasionally knee arthritis can actually make your knee not be in the proper alignment. And so your foot and ankle have to compensate for your knee. So if your knee has a little bit more of a knock-knee position, that means that your foot has to compensate by everting or turning out, and that can stress your tendon. So sometimes actually getting the knee realigned straight helps your foot and ankle because it's not getting stressed to try to keep your foot flat on the floor by having to twist to do that. So that's one thing that may help. Obviously, we have to kind of look at your exam and other things history-wise to make sure that that would help. The other issue is getting a good arch support. So you can get some over-the-counter arch supports to try first. They come in the full-length type that goes the full length of the shoe and have a foam arch. And so those are a little bit better for supporting your arch. If you give arch support, that gives the posterior tibial tendon a rest and lets it not be so irritated. And so that's a good thing to try. The full length ones I like better than the short 3/4 length ones, but the full length ones take up a little bit more room in the shoe. So generally you would do that in an athletic shoe where you can take out the insert the shoe comes in with and put your orthotic in instead, the one that you buy. If that still doesn't work, then sometimes custom orthotics, we can have a little more control of your foot position than an over-the-counter one. So there are some strategies. Therapy sometimes helps, icing, elevating, doing some, taking some Aspercreme or Voltaren gel, sometimes massaging the area helps kind of move some of that swelling out and helps relieve some of the pain. High impact activities like doing a lot of Stairmaster or doing a lot of steps, things that require a lot of pushing off with your foot can really aggravate the tendon. So I'd avoid running, jumping, Stairmaster, doing any toe raises or repetitive push off with your toe when you're doing your exercise program, because that'll really stress the tendon out. So you want to do the biking, you want to do the swimming instead. Maybe not push off the wall, but you can walk in the pool. You can touch with your hand instead of flipping on the ends. But those are ways to kind of give the tendon a little bit of a rest. Generally, it will resolve.
Great. We have 2 questions left. This question is from Judy. I had bunion surgery over 30 years ago in both feet. They have returned over the years and my feet hurt all the time. I'm a distance runner. The joints from the surgery are full of arthritis. Is surgery an option?
So yeah, it would depend on your personal, expectations, what you want to do, what your bucket list is, and also discussion on like your medical history and physical exam findings, obviously. So I can't really give specific advice for certain, but I can give you some just overall guidelines. So there does come a point sometimes where the function is to the point where you can't do what you need to do or want to do. And so surgery obviously is an option if the things that you've tried haven't worked with respect to, wearing a shoe that has more of a stiff sole so that the MTP joint or the great toe joint doesn't get as much stress. If you've tried, the orthotics, if you've tried, mixing up your training so you do a little bit more cross training, high and low impact type of activities. Surgery generally is in 2 categories. Because of the damage to the cartilage, we usually have to either do a fusion procedure where you actually fuse the metatarsal bone to the phalanx bone to get rid of the arthritis, which makes a nice stable first great toe to push off from. And you can still run. You don't have to not run if you have a fusion. There's actually pretty good data on that. The other option is replacement. Replacement in the foot and ankle is getting better, but it's not as reliable, unfortunately, as the hip and knee replacements. The foot and ankle, such small joints, very high stress across them, and very little bone to work with. And so it's been a challenge to come up with good replacements for the foot and ankle. We're getting there, but there's a lot of work to do. The knee and hip replacements are pretty much the most reliable procedure in medicine. And so replacement for an active person that likes to run is maybe not ideal, but again, that's kind of a discussion to have with your doctor or your surgeon.
Great. And the last question comes from Kathy. So there's been a lot of marketing of these vibrating machines lately for pain relief, muscle tightness. Are these good for feet?
Yeah, that's a tough one just because the force of those vibrating devices is usually pretty strong and sometimes can aggravate the soft tissue because the foot, unfortunately, is just skin and bone or tendon in some places. It's not like your thigh muscle where you can use like a therapy gun and like really work out the tightness of the muscle. Unfortunately, if you do that in the foot on the fascia, it can actually make it hurt more. It's just we don't have the padding down there. So unfortunately, the foot and ankle, I haven't seen too much of a good use for it just because it works with some people, but some people, the majority of people I see, it tends to make them more sore. And sometimes things like Graston, where you take a metal device and actually push on the bottom of the foot, it's a very sensitive area. And I haven't really found that it was, it helps some people, but I find a lot of people get worse with it. So you have to be pretty careful if you're going to do it in the foot. I would do like very, very minimal setting. Or you can do the low tech option like a tennis ball and just roll the bottom of your foot on a tennis ball to kind of help get some of that swelling and soreness out.
Great. Well, Dr. Miskovsky, thank you so much for your time this evening and sharing all of this extremely helpful information and answering all the great questions that we received. And to our attendees, thank you for spending your evening with us. Just a few reminders for the audience. We will be emailing you a link to view this session again, if you'd like to watch it over again. And we'll also have this available on our website soon. So if by any chance you're interested in scheduling an appointment with Dr. Miskovsky, you can schedule that appointment at 216-243-2028. That's 216-243-2028. And if you need more information, feel free to go to our orthopedics website. It's at uhhospitals.org/ortho. So this concludes tonight's session. Again, thank you for attending, and we hope you join us for future upcoming webinars. Have a great evening, everyone. Thank you.